Can everybody hear me?
Yes, we can hear you, sir.
Ma'am, I could not hear you. The introduction is that's okay. Can I start?
Yes, sir, you can start the lecture.
Okay. Thank you, Jitma, for kind introduction, and good evening, everybody. Uh, I'm Saman Kumara, Neonatologist from Castle Street Hospital. So today's topic is volume guarantee ventilation. Uh, uh, I will start with some basics. So next 30 minutes, I will be touching on the basics of mechanical ventilation and introduction to volume guarantee ventilation or volume target ventilation and impact on lung injury and pressure control ventilation versus volume control ventilation and some evidence for volume guarantee ventilation and how to start and how to do the weaning and extubation. Um, so the basics of mechanical ventilation, what is important to remember, I'm doing this in both languages, Russian and English. So what is important to remember is the basics of mechanical ventilation will not change. Whether whether it is whatever the mode of ventilation, the lung physiology, the physiological basis of ventilation remains the same. So there are two important things when you do ventilation, when we ventilate any patient, it may be a newborn, pediatric patient, or adult. There are two things that we need to do from the ventilator. One is oxygenation, or to maintain satisfactory saturation and adequate carbon dioxide removal. So these two are the main aspects of mechanical ventilation. And when you talk about oxygenation, the factors affecting oxygenation will be FiO2. අපි ඒක හැමෝම දන්නවානේ. ඔක්සිජනේෂන් වැඩි කරන්න අපි ඉස්සෙල්ලම කරන දේ තමයි FiO2. අපි දෙන ඔක්සිජන් ප්‍රමාණය adjust කරනවා. So FiO2 starting from 21% to 100%. I'm discussing from very basics because I think there are nurses and the doctors. There's a mixed crowd. I'm touching from very basic steps. So you see again, you see again 100% යනකම් ඔක්සිජන් වැඩි කරන්න පුළුවන් කියලා අපි දන්නවා. ඒකට ඔක්සිජන් වැඩි කරන එක තමයි සිම්පලිම අපිට කරන්න පුළුවන් දේ patient කෙනෙක්ගේ ඔක්සිජන් වැඩි කරගන්න FiO2 saturation වැඩි කරගන්න. අනිත් එක තමයි the other important thing is the mean airway pressure. So for oxygenation there are two things affecting the FiO2 and the mean airway pressure. These are very basic principles of mechanical ventilation. අපි බලමු mean airway pressure කියන්නේ මොකක්ද කියලා. ඒතකොට අපිට FiO2 වැඩි කරත් oxygenation වැඩි හදාගන්න පුළුවන්, improve කරගන්න පුළුවන්. මොනවා හරි ක්‍රමයකින් mean airway pressure කියන එක වැඩි කරගන්න පුළුවන් නම් ඒ oxygenation improve වෙනවා. මම අපි කතා කරමු mean airway pressure කියන්නේ මොකක්ද කියලා. So mean airway pressure කියලා කියන්නේ මේක පොඩ්ඩක් හොඳම diagram එකක් නෙවෙයි මම මේ ඉන්ටර්නෙට් එකෙන් ගන්න එකක්. මේක තියෙන්නේ peep එක. PEEP. මේ තියෙන්නේ 0. මේ ලයින් එක 0. මේ අංක දාලා නැහැ. මේ ලයින් එක 0. මේ පැත්තට ටයිම් එක, මේ පැත්තට ප්‍රෙෂර් එක. එතකොට අපි පටන් ගන්නේ බ්‍රෙත් එකක්. මෙකැනිකල් බ්‍රෙත් එකක් පටන් ගන්නේ ප්‍රෙෂර් එක බිඳුවෙන් නෙවෙයි. අපි හැමෝම දන්නවා. මොකද අපි හැම වෙලාවෙම වෙන්ටිලේට් කරනකොට පීප් එකක් සෙට් කරනවා වෙන්ටිලේටර් එකේ. PEEP කියලා පීප් එකක් සෙට් කරනවා. ඒ පීප් එක හැම වෙලාවෙම මෙකැනිකල් බ්‍රෙත් දෙකක් අතර ඇල්වියලා ලං එක ඇතුලේ ප්‍රෙෂර් එක බිඳුවටම බහින්න දෙන්නේ නැහැ. යම්කිසි ප්‍රෙෂර් එකක් තියාගන්න. ඒ අපි මේ ප්‍රෙෂර් එක නැචරලි අපි තියාගන්නේ අපි හුස්මක් ගත්තාම මේ හුස්ම පිට කරනකොට යම්කිසි ප්‍රමාණයක් අපි vocal cords වහලා ලං එක ඇතුලේ ඉතුරු කරගන්නවා. residual volume එක. ඒ residual volume එකත් එක්ක තමයි අපි natural PEEP එකක් maintain කරන්නේ. අපි intubate කරපු නැති අපි සාමාන්‍ය දැන් මේ අපි ඕගොල්ලෝ හැමෝම අපි හුස්ම ගන්නකොට natural PEEP එකක් maintain කරගන්නවා. එපිග්ලොටිස් එක වහගෙන බ්‍රෙත් එකක් අවසන්. එතකොට ඉන්ටියුබේට් කරපු patient කෙනෙකුට ඒක කරගන්න බෑ මොකද අපි ඒක bypass කරලා තියෙනවා. නැත්නම් අපි machine එකෙන් අනිවාර්යයෙන්ම set කරන්න ඕන PEEP එක. ඒතකොට මේ PEEP එක ඔයගොල්ලෝ ගන්නවා සමහරට 5ක් 6ක් සමහරට maybe even 7 වෙන්න පුළුවන්. ඒක breaths දෙකක් අතර mechanical breaths දෙකක් අතර මේ පීඩනය හැම වෙලාවෙම ළඟ ඇතුලේ තියෙනවා. So we are maintaining that peak. And with that, when the time is okay, the mechanical breath will be delivered. Time is okay means if you are on SIMV, if the baby takes a breath, and machine will most likely overlap the mechanical breath with the baby's breath and deliver a fully controlled mechanical breath. Right? So එතකොට මේ මෙතන peak එකෙන් පටන් අරගෙන එතනින්ද pressure එක වැඩි වෙනවා. pressure එක වැඩි වෙනවා. pressure එක එක ගානකට වැඩි වෙනවා. ඒ ගාන තමයි මේ dotted line එකෙන් පෙන්නන්නේ. ඒ ගානේ නවතිනවා. ඒ dotted line එක තමයි අපි set කරපු pip එක. PIP අපි set කරපු pressure එක. ඒකට මේ pressure එකට ආවට පස්සේ අපේ inspirate time එක ඉවර වෙනකම්ම ඒ pressure එකේ machine එක ඉන්නවා. ඒ pressure එක maintain කරගෙන ඉන්නවා ලං එක ඇතුලේ. ඊට පස්සේ inspirate time එක ඉවර වෙච්ච ගමන් expiration phase එකට යනවා. මේක මෙච්චරම ස්පීඩ් නෑ. ඒක වඩා පොඩක් ස්ලෝප් එකකට ආපහු යන්නේ බිඳුවට නෙවෙයි ආපහු යන්නේ ආපහු පීක්. එතකොට mean යාවේ pressure එක කියලා කියන්නේ මේ respiratory cycle එක. මේ respiratory cycle එක ඇතුලේ පටන් ගන්න තැන මෙන්න මේ ඇතුලේ මේ සම්පූර්ණ ක්‍රියාවලිය ඇතුලේ මේ එක breath එකක් ඇතුලේ මේ එක mechanical breath එකක් ඇතුලේ समस्त pressure लंग එක ඇතුළේ තියෙන ලං එක ඇතුළේ අපි කියන අදහස් ගන්න alveoli. So mean pressure means the average pressure within the alveoli during one breath, right? So that average pressure is proportionate to the oxygen. If you can increase the average pressure during the one mechanical cycle, if you can increase the average pressure, that will increase the oxygenation. So simple as that. But what is important is how to increase the mean airway pressure. Now, it is not that simple. So, may area එක තියෙනවනේ මේ curve එකේ මේ pressure curve එකේ area මේ area එක under the curve area එක වැඩි කරන්න පුළුවන්. මේ area එක වැඩි කරන්න පුළුවන් ඕනම ක්‍රමයකින් mean airway pressure එක වැඩි කරන්න. So area under the curve is directly proportionate to mean airway pressure. එච්චර මේවා ගැන හිතන්න ඕනේ නැහැ. I'm just trying to explain for the doctors and the other people. So if you can increase the mean area under the curve, then that will proportionately increase the mean airway pressure, and that will proportionately increase the oxygenation. එතකොට මේ area එක මේ curve එක වැඩි කරගන්න මොනවද අපිට කරන්න? පැහැදිලිවම පේනවා පීප් එක වැඩි කරොත් area under the curve වැඩි වෙනවා. පීප් එක වැඩි කරොත් area under the curve is increasing, and in turn the mean airway pressure will go up and oxygenation will go up. And if you increase the pip, අපි set කරමු pip එක අපි හිතමු දැන් මෙතන 16 නම් මේ තියෙන්නේ අපි මේක 18ක් කරොත් ඒ curve එක මෙතෙන් යනකම් වෙනවා. So එතකොට ඒක area under the curve වැඩි වෙනවා. ඒකම අපි යම් කිසි විදියකින් අපේ flow එක වැඩි කරන්න පුළුවන්. දැන් මේ මෙච්චර steep වැඩි වෙන්නේ නැහැ අතර මේ රූප සටහනක මේ සාමාන්‍ය වැඩි වෙන්නේ මේන්න මේ විදියට. කොහොම වැඩි වෙන්නේ. ඒතකොට flow එක ventilator එකේ flow එක අපි දන්නවා flow එකක් කියලා තියෙනවා. flow එක 8 10 ඒ වගේ flow එකක්. යම් කිසි විදියකින් flow එක වැඩි කරොත් මේ pip එකට achieve කරන time එක අඩු වෙනවා. ඒතකොට ඉක්මනට pip එකට achieve කරනවා. එතකොට area under the curve එතනත් වැඩි වෙනවා. ඒතකොට ඒව ටිකක් අපි එච්චර handle කරන්නේ නැති එක. අපි handle කරන්නේ මොනවද? mean airway pressure එක වැඩි කරන්නේ mainly peep එක සහ pip එක. So if you increase the peep, that will increase your area under the curve, and that will increase your mean airway pressure. If you increase the peep, that will also increase the mean airway pressure and area under the curve and mean airway pressure and the oxygen pressure. So that's how it works. So this is applied to whatever the mode of ventilation. So this is the diagrammatic representation of a mechanical breath in conventional ventilation, but it is the same with high frequency ventilation, or whether you are ventilating a patient with pressure control or volume control, this principle is same. It will not change. So the same thing with carbon dioxide. I'm not going to discuss that. I just wanted to mention about oxygenation. Carbon dioxide washout is again tidal volume and minute volume. The minute volume means tidal volume into rate. And if you want to have more carbon dioxide wash out, you have to increase the tidal volume, and also you have to increase the rate. Then that will increase minute volume. So I'm not going to talk in that on that because it's going out of the topic. So the point is the basics do not change. Whether you are using pressure control, volume control, high frequency ventilation, these are only different modes, right? So the basics will remain the same, right? So coming back to volume guarantee ventilation, and the questions are, how familiar are we? Now, idea of this lecture is also to make the staff, NICU staff, the doctors, and everybody little aware about volume guarantee ventilation, because this is becoming the more favorable or preferred mode of ventilation for newborns also. Volume guarantee ventilation was used for newborn ventilation some time back, but it was given up for a period, but it's coming again. So then volume guarantee ventilation කියන එක තමයි ගොඩක්ම preferred ventilation mode එක විදිහට newborns එකත් පාවිච්චි කරනවා. ඒක හන්ද ඒක හේතු තියෙනවා අපි ගැන කතා කරමු. ඒක හන්ද අපි මේ ගැන දැනුවත් වෙන එක හොඳයි. ඒක හන්ද තමයි අපි මේ lecture කරන්න අදහස් කරේ. So අපි කොච්චර familiar මම හිතන්නේ අපි කවුරුවත් familiar නැහැ. To be honest, even I am not very familiar because practically we have not been doing volume guarantee ventilation. But we can't be staying in the same place, but we need to know this and we have to experience this and we have to start with this. And how many of us use it? මම හිතන්නේ අපි ගොඩාක් වෙලාවට අපි ගොඩක් මේ පාවිච්චි කරන අඩුයි. ගොඩාක්ම අපි කැමති පුරුදු වෙලා ඉන්නේ pressure control ventilation. Volume control ventilation නෙවෙයි. ඒක පුළුවන් අපිට මේක කරන්න practice කරන්න. ඇත්තටම පුළුවන්. ඒකට මොනවද තියෙන ප්‍රශ්න? So know your ventilator. So there's one very important message I have to convey. If you are doing the volume guarantee ventilation, you have to know your ventilator. මොකද්ද පාවිච්චි කරන ventilator? එතකොට මේ ventilator එකේ අපිට volume guarantee ventilation කරන්න පුළුවන්ද කියන එක අපි තීරණය කරන්න ඕනේ. ඒකට එන්න කලින් පොඩ්ඩක් කියන්න මොකද මේ ventilator ගැන මම පොඩ්ඩක් තව වෙලා අරගෙන කතා කරන්න ඕනේ. හැම ventilator එකකින්ම volume guarantee ventilation කරන්න බෑ. Because now every ventilator that we are using, you name it, every ventilator will give the volumes, tidal volumes, minute volumes, inspiratory tidal volume, expiratory tidal volume. Every ventilator will give. But if you are doing the volume ventilation, if you want to do volume ventilation, your volumes must be very accurate. The volumes must be very accurate. So I want to highlight that fact. The volumes that are measured by the ventilator should be very accurate to do the volume guarantee ventilation. Otherwise, it will become very risky business. So how do we know whether the volumes which are measured by the ventilator is accurate? That is the question. Now, I want you to remember the patient circuit. All of you can remember the patient circuit. And you know some ventilators have a gadget called flow sensor. There's a gadget called flow sensor. I'm sure the nurses and the doctors and everybody knows this. The flow sensor is connected to the ET tube, and then the ventilator circuit is connected to the flow sensor. So the flow sensor will come between the ventilator circuit and the endotracheal tube. So that is this can be, the flow sensors can be, there are different types. It can be a pressure sensor, it can be a flow sensor. So whatever it is, the measurements are taken proximally. Proximally means proximal to the patient or the baby. In other words, the measurements are taken at the patient end. That is close to the ET tube. So that is one type of ventilator that you will see. I can give you examples. Sophie will have flow sensor at the patient end, proximal, and acutonic will have the same. And then there's another one. It just come to but the other very famous most commonly used ventilator, which is Newport ventilator, you will notice that there is no such thing coming between the endotracheal tube and the ventilator circuit, which means it is not taking the proximal measurement. So the machine which takes the measurements or the volume measurements proximally, in other words, close to the baby, close to the endotracheal tube, that will give a better or more accurate volumes measurements. The machine which does not do that still continue to take the measurements. Still, the machine will tell you how much of a tidal volume is delivered. එතකොට A machine වල flow sense එකක් endotracheal tube එක ගාවට high වෙන්නේ නැහැ. කිසිම විදිය flow එකක් කිසිම විදිය measurement එකක් endotracheal tube එකට ආසන්නයෙන් ගන්නෙ නැහැ. ඒක ගන්න within the machine. So they are still, the machine is still measuring the volumes within the machine before the patient surgery. So there can be a lot of volume loss, and the accuracy of the volume is not very good. So therefore, those machines, if you are using those machines, then the volume ventilation is not very accurate, and it can be dangerous. So I hope the point is clear. So know your machine first and see whether the machine takes the volume measurements at the patient end before you do the volume cavity ventilation. That's a very important message. So there are confusing modes of ventilation, different modes, but why are we bothered? The optimal ventilation and oxygenation is our priority, and there are various types of modes, but what is important is the minimal patient discomfort. The patient should be very comfortable, and there should be minimal lung injury. Whatever the mode you are using, these things should be fulfilled. Optimal ventilation, oxygenation, minimal discomfort to the baby, and a minimal lung injury. And what is important to remember, although we know about various types of modern types of ventilation modes, what is important to remember is endotracheal ventilation is always more damaging than non-invasive ventilation. So if there's need only, you need to pass an endotracheal tube and ventilate. And always see whether you can manage this baby without putting a tube down, without going for invasive ventilation. And if you can manage with non-invasive ventilation, it's very clear that you are doing less damage to the baby's lungs. So that is another important message, right? And I told you just this ventilation and the oxygenation. And okay, so neonatal ventilation and lung injury. Any type of respiratory support will damage the baby's lung. Right? Whether it is invasive, non-invasive, it will still damage the lung. But as I said, invasive ventilation will do more damage. And even 5 inflation breaths that you are given in the labor room or the operation theater for a baby, that will cause some amount of lung damage, and especially so for premature babies. So, but these are sometimes unavoidable. You have to resuscitate the baby, you have to give inflation breath, you have to give ventilation breath, you have to give non-invasive, you have to be invasive. These are, you have to do this. But point is, try to avoid as much as possible. And pressure is not the only culprit. Pressure is not the only culprit. Pressure is damage. And this is called barotrauma. But the barotrauma and the pressure is not the only culprit. But volume. Api pressure ka control karat. Api control pressure ka local volume में deliver करना lungs, that will still damage volume, the lungs. So this is called volume trauma. And not only that, high volume will damage lungs, as well as the low volumes also will damage lungs. That's called atelectatic trauma. If you are not expanding the lungs properly, the alveoli are collapsed at the end of expiration. Then from the collapsed state, the alveoli have to reopen. So that will cause unnecessary collapse and reopening of the alveoli. So that also will contribute to lung injury. So all these are causing damage to lung injury, and we should try our best to minimize this barotrauma, volume trauma, and atelectatic trauma. And there are other traumas, but these are the main ones. Right. So if you look at this X-ray, I'm sure all of you are familiar with this kind of X-rays, and this is one patient, same patient, and you can see a premature baby. You can see the ground glass appearance of the lungs and some degree of air program and intubated baby. And there's a lot of atelectasis and lungs are collapsed. And the aeration is very poor. And why are we seeing this as white? Because alveoli are mostly collapsed. And this is after surfactant. This is after surfactant. And what has happened? Now the alveoli are open. That's the magic of surfactant. So it has opened fully. And if you actually look, it's overexpanded. The diaphragms are flat. Diaphragmatic domes are flat. And you can count the number of spaces. So it's slightly overexpanded. So this is damaging. If you ventilate this baby without giving surfactant, you will still aerate the lungs with high pressure, and there are a lot of atelectasis at the end of expiration, and that will cause a lot of damage. And you will have to use a lot of pressure to open this lung. So there's pressure damage and the atelected trauma. And when you look at this one, now it is well expanded. And if you are ventilating, if you are not looking at your volumes, and this is where the volume comes to picture in clinical practice, you may be happy. This may be having nice oxygenation and maybe very good carbon dioxide, acceptable carbon dioxide level, and you are happy, everything is fine. But if you look at the lungs, it's overexpanded, and we may be delivering through the intertracheal tube unnecessary volume of air, which is causing volume trauma. This is why the volume guarantee ventilation is important and comes into practice. So lung injury, this is the normal lung, histology of the normal lung, and this is after few hours of after 6 hours of ventilation with low pressure, low peak pressure, and this is high peak pressure. Right? So both are damaged, and you can see high peak pressure causes more damage. So this is what happens to our baby's lungs after few hours of ventilation with mechanical ventilation. So you can see how bad it is, and the ventilation, how badly the ventilation, mechanical ventilation can damage lungs. So ventilator-induced lung injury is a very famous popular term, but what you have to do is to optimal lung volume, use optimal lung volume and open lung ventilation strategy to minimize the ventilator-induced lung injury. So minimize end expiratory alveolar overdistension. At the end of inspiration, as I told you in the X-ray, I showed you in the X-ray, there should not be overdistension. If you minimize the overdistension, that will reduce the volume trauma and optimize the functional residual capacity by reversing the atelectasis. So by giving surfactant and by maintaining a reasonable PEEP, you prevent atelectasis, and that's called recruitment. So that will minimize atelectasis trauma and stabilize the lung units through the respiratory cycle, and that will prevent that. Also will prevent atelectasis trauma. So all these efforts are to minimize the lung injury as a result of volume trauma. Right. So now we are talking about volume ventilation and the pressure control ventilation. Now, before we know about volume control ventilation, we need to see what is happening in pressure control ventilation. So I have just made some diagrams. So you're familiar with this picture. This is mechanical ventilation. Say, for example, SIME breath. So this is the PEEP, and then the mechanical breath, and at the end of your when you achieve the inspiratory pressure, peak inspiratory pressure, it will not go beyond that, and it will stay until the inspiratory time is over. I mean, PIP එක ආවට පස්සේ inspiratory time එක ඉවර වෙනකම්ම PIP එකේ ventilator එක lung එක ඒ ගන්න තියාගන්න. So at the end of inspiratory time, you go for the expiration. So this is expiration. මේ ඔක්කොම ටික expiration. එතකොට breath එකක් දෙනකොට අපි දැන් ඉස්සෙල්ලාම ventilator connect කරලා pressure control ventilation, we have set the peak inspiratory pressure and we have set the peak and inspiratory time, all that, and we just connect. And these things will never change in after that. So unless you change the PEEP and the rate manually, these things will be same for next few hours until you make the change. So එකත් එක්ක මොකද වෙන්නේ tidal වලින්. මේ breath එකත් එක්ක මේ පළවෙනි breath එක. So say just imagine this is the first mechanical breath delivered to the baby. So you give a dose of surfactant and then you connect the baby to the ventilator, and this is the first breath, and that will deliver a certain tidal volume. පළවෙනි breath එකේ tidal volume එකක් deliver. Right? So the lung will expand to some extent. And then in the next breath, it will deliver another higher tidal volume, because lungs are, with each breath, lungs are expanding, alveoli are expanding. And we have no control. And it will continue to expand. So say for example, this is the fully expansion, and just imagine the X-ray which I showed you after surfactant. So with this peak inspiratory pressure, so this is the tidal volume. So you can understand with same pressure, the tidal volume will continue to increase until it reaches the maximum tidal volume with that lung compliance of the baby. So this tidal volume will depend on the lung compliance, depending on the lung pathology, lung compliance. So depending on lung compliance, with the same peak, it will recruit alveoli and then come to a maximum tidal. So this is what happens. We have no control, and we don't know whether this is a required tidal volume for this baby. And we know this may be small, but we don't know whether this is too much. But we have no control. We have control only over the pressure, but we have no control over the tidal volume which is delivered. The tidal volume කියලා අපි කිව්වොත් ඒක තවත් පැහැදිලි කරොත් එක mechanical breath එකකදී patient ගේ එහෙම නැත්නම් බබාගේ පෙනහළු වලට යන වායු වොලියුම් එක වායු ප්‍රමාණය මිලිලිටර් විදියට මෙච්චර වායු ප්‍රමාණයක් එක breath එකකදී පෙනහළු වලට යනවා. ඒතකොට යන ප්‍රමාණය තමයි අපි tidal volume කියලා කියන්නේ එක breath එකකදී. ඒතකොට පළවෙනි breath එකේදී අඩුවෙන් යනවා මොකද lungs expand වෙනවා. එහෙම වෙලා කාලයක් එක්ක breath කීපයක් යනකොට tidal volume එක වැඩි වෙනවා. ඒක maximum ගානට එනවා. ඒ maximum ගානට ආවට පස්සේ ඒක වෙනස් වෙනවා. ඊට පස්සේ ඒක දිගටම ඒ tidal volume එක දිගටම deliver වෙනවා. අපේ ප්‍රශ්නේ තියෙන්නේ මේ තියෙන tidal volume එක අපි දන්නේ ප්‍රමාණය වැඩිද මදිද කියන එක අපි හරියට දන්නේ නැහැ. අපි ventilator එක දිහා බැලුවේ නැත්නම්. ඒකෝට අපි හරියට measurements දෙන ventilator එකකින් නම් ventilate කරන්නේ pressure control ventilate mode එකේ. Then you can see this tidal volume in the screen and you will know how much of tidal volume. But I don't know how many of us are looking at this tidal volume in pressure control ventilation. But still you can look at the tidal volume and you can adjust your pressures. But I think we are not really looking at it. So how to minimize lung injury when on pressure control modes? Now, as we are used to pressure control modes, but still we can do something. Until we get used to the volume control ventilation, we can do certain things to minimize lung injury. Right. Being PEEP when oxygenation and carbon dioxide is accepted. Right. When you have the good oxygenation and after giving surfactant, because the starting pressure may be 16 or 18, because there's a blind pressure. We don't know whether that pressure is too much or not enough. But if you have achieved good oxygenation and carbon dioxide, please make sure that whether you can drop down your PEEP, right? So the PEEP එක අඩු කරගත්තොත් අපිට damage එක අඩු කරන්න පුළුවන්. When carbon dioxide is washed out, that may be due to high tidal volume. Carbon dioxide wash out වෙලා නම් tidal volume එක වැඩි හන්ද වෙන්න පුළුවන්. So tidal volume එක වැඩි වෙන්න පුළුවන් හේතු දෙකක් තියෙනවා. එකක් තමයි rate එක වැඩි වෙන්න පුළුවන්. අනිත් එක තමයි අපේ PEEP එක වැඩි වෙන්න පුළුවන්. So මේ දෙකෙන්ම අපිට අඩු කිරීම නිසා tidal volume එක අඩු කරගන්න. So always get used to reading the tidal volume on the screen. And even if you are on pressure control mode, please make sure that you look at the tidal volume on the screen. But again, I want to highlight, this will be accurate only with the proximal measurements from the ventilator. Right. So problem is tidal volume changes with the improved compliance. When you give surfactant with the first breath, the compliance will not improve. But with time, the compliance will improve. So with each breath, as I showed you the previous slide, which each breath with the improvement of the lung compliance, the tidal volume will increase because we have no control over the tidal volume. Right. So this is what I said. Distal volume measurements are not accurate. So just we have enough spoken about. So pressure control versus volume control. So pressure control, the only difference is the pressure control, the pressure is static and you set the pressure, right? අපි තමයි pressure එක set කරන්නේ. අපිට pressure එක අපි pressure එක තමයි control කරන්නේ. So pressure එක throughout the ventilation ventilation episode එකේ pressure එක වෙනස් වෙන්නේ නැහැ අපි manually වෙනස් කරන්නේ නැත්නම්. But volume is variable. We don't know how much volume is delivered. Depending on the pressure you set, the volume becomes variable depending on the lung compliance. So the lung එක stiff නම් volume එක අඩු වෙන්න පුළුවන්. lung එකේ stiff ගතිය අඩු වෙනවා surfactant දුන්නා නම් lungs open වෙනවා. එතකොට deliver වෙන volume එක වැඩි වෙන්න පුළුවන්. So this is the simplest way I can explain this. Volume control in pressure control I said you set the pressure, but volume control you set the volume you set the volume, and the volume is static. You ask the machine, okay, I want you to deliver only this much of milliliters of air during one breath, and you are telling you are commanding the ventilator about the volume. But here you are commanding the ventilator about the pressure. You are asking the pressure, okay, ventilator, you can deliver breaths at the pressures of this, the PEEP of this and the PEEP of this. But in volume control, you are asking the machine, you can deliver only this much of volume in one breath. So that means you are setting the volume. But what happens to pressure? The pressure becomes variable. So machine will do the job that you have asked the machine to do, deliver the set volume at the expense of the pressure. So we have no control of the pressure. So you can't ask the machine to control the pressure also, but you can control the pressure in a different way. I'll come to that. So pressure will be variable, but machine will deliver the target tidal volume which has been asked by the operator. So that's the difference. So if you can just understand this diagram, what happens is this is the PEEP again, and we have set the target tidal volume. We have asked the machine to deliver a tidal volume. Now this is the target tidal volume, right? Say for example 5 milliliters per kg, just for explanation purposes. If the baby is say 1 kilo baby and you have asked the machine to deliver, you can set the tidal volume 5 ml per kg. So which is 1 kilo baby, it will be 5 ml, right? So this is the target tidal volume, and you ask the machine to deliver only 5 ml per kg per breath. And the PEEP, we are not going to set the PEEP. PEEP එක අපි set කරන්නේ නැහැ. PEEP එක අපි set කරන්න බෑ ඇත්තටම. එතකොට ඒ machine එක, the machine will deliver the first breath. Okay, so machine has to understand the lung compliance. It will not do the job with the first breath. So that is something that we need to understand. Machine has to give couple of breaths and understand lung compliance and to come to a conclusion. Okay, this much of pressure I have to use to deliver this much of tidal volume. So machine will give the first breath. This is the PEEP, and it will deliver tidal volume. So this is the tidal volume delivered with that PEEP. Is that enough? No, that is not enough, because our target tidal volume is this. So machine is delivering a tidal volume which is smaller than what we have asked the machine to do. So what the machine does next, because the feature of the machine is every breath is analyzed by the machine, by a computer within the machine. So machine will analyze the previous breath, and then machine knows, okay, my previous breath I have not been able to deliver the required tidal volume. So what the machine does is machine will use a higher pressure. So we are not setting the pressure because pressure is not under our control. Machine will use a higher pressure, and then it will deliver a higher tidal volume. Always when you deliver a higher pressure, that will obviously deliver higher tidal volume. So වැඩි pressure එකක් machine එක පාවිච්චි කරනවා. වැඩි pressure එකක් පාවිච්චි කරාම tidal volume එක වැඩි tidal volume එකක් deliver කරනවා. Right? එතකොට තාමත් අපේ tidal volume එක achieve කරලා නැහැ with the second breath. So machine analyzes the previous breath. Always before the next breath, it analyzes the previous breath. So machine will understand, okay, I have still not delivered the required tidal volume. So it will increase the pressure again. Next breath, it will give a higher pip. And with that, you get another tidal volume. Okay. So machine analyzes that and realizes, okay, my God, I have used a pressure and now I am delivering a tidal volume which is higher than which I have been asked to deliver. So this is the target tidal volume level. And then the machine will also alarm and machine will tell you, look, you are delivering more than required tidal volume. And then what does the machine do? Machine will readjust the pip so that the tidal volume comes to the required tidal volume. So this is done by the computer and machine will analyze each and every bit, and this will continue to happen. For each and every bit will be analyzed by the machine before the next bit is given, so that target tidal volume is delivered. And this pressure we are not deciding, the machine is deciding, the computer will decide how much of pressure is required. Now it doesn't stop there. Now this is the first few breaths. And what happens? Now machine knows this is the target tidal volume, and with the improvement of lung compliance, if for example, if it is surfactant deficient lung disease, with time, within few hours, the lung compliance will improve. So what happens? The machine will tend to deliver with same breath, same pip. After few hours, the machine will deliver a higher tidal volume. So it will adjust. It will adjust by dropping the peak, and it will try to deliver the target tidal volume which has been asked to deliver. So this is not happening 100% between these two lines. It will go a little this way, that way, but it will not go all over the place. And machine will always try to maintain the tidal volume within this limit. And we can ask the machine to do another thing. We can put a kind of we can ask the machine to okay, you do this, but you can't exceed your pressure more than this. So this is your, that's called pressure control volume guarantee. Pressure control. But you can't control this pressure, but you can put a upper limit of the pressure. Say for example, you can put, say, 26 centimeter water upper limit. 26 centimeter water upper limit, then the machine will try to deliver. And if the machine can't deliver the tidal volume, required tidal volume with below 26 centimeter water, then the machine will alarm. Machine will say, okay, I can't deliver this much of tidal volume with the pressure limitation that you have set. So machine එකට අපි කියනවා limit එකක් දානවා centimeter water 26. 26ට වඩා යන්න බෑ. එතකොට 26ට වඩා machine එක යන්නේ නැහැ. So එතකොට machine එකට ඒ 26ට වඩා යන්න බැරි නම් ඒ 26ත් එක්ක tidal volume එක deliver කරන්න බැරි නම් machine එක alarm. So I hope that is clear to everyone. So then with subsequent breaths, depending on the lung improvement, the compliance improvement, the machine will adjust the peak inspiratory pressure. It will drop. If the compliance becomes poor, then the pressure will go. So throughout this ventilation, pressure will go up and down. But if you are lucky, if the patient is lucky, if the compliance is improving steadily, what will happen is this pressure will steadily go down to deliver same tidal volume. Right. So this is what happens. Right. So subsequent breaths. Now patient is in more stable ventilation. Same pip is used, but the same tidal volume is delivered. And with time, with the improvement of the lung compliance, the same tidal volume will be delivered with lower pip. And you can see this is called auto weaning of pip. And normally what we do with pressure control ventilation, oxygenation හොඳයි නම්, gas එක හොඳයි නම්, FiO2 requirement එක අඩුයි නම් අපි manually මේ pip එක අඩු කරනවා. Manually අඩු කරනවා. 16 දුන්නා 14ක්. 17 දුන්නා 12ක්. එහෙම අපි අතින් බල අතින් අඩු කරගෙන යනවා. Maybe 6 hourly or 4 hourly or depending on patient improvement speed අපි අඩු කරනවා. නමුත් මේකෙදි වාසිය තමයි මේ පිප් එක ඔටෝ වීන් වෙනවා tidal volume එක deliver කරන්න අවශ්‍ය පිප් එක අනුව ඔටෝ වීන් වෙනවා. එතකොට අපි කාලයත් එක්ක පිප් එක අඩු වෙගෙන යනවා. ඒක less damage and we are not delivering unnecessary volume and we are not using unnecessary pressures. Right. So මේක ඒකම තමයි pressure control versus volume control. Volume control එකේදී සාමාන්‍යයෙන් volume control එකේදී pressure change වෙන විදිය volume control එකේදී pressure control එකේ ලොකු වෙනසක් නැහැ. But volume change වෙන tidal volume change වෙන විදිය ලොකු වෙනසක් නැහැ. නමුත් එයාගේ pressure change වෙන විදිය පැහැදිලි වෙනසක් තියෙනවා. මොකද එයාගේ pressure එක change වෙන එක pressure control එකේදී බොහොම ඉක්මනට pressure එක pip එක achieve කරනවා. pip එක achieve කරලා inspire time එක ඉවර වෙනකම්ම ඒ ගාන තියෙනවා. ඒක ලොකු pressure එකක් ළඟ ඇතුලේ තියෙනවා. volume control එකේදී වෙන්නේ inspire time එක දිගේම slowly තමයි pressure එක වැඩි. So drop is there. The flow is again something different with volume control and the pressure control. The volume control එකේදී flow එක ඉක්මනට වැඩි වෙනවා. වැඩි වෙලා ඒ flow එක maintain වෙනවා inspire time එක පුරා. නමුත් pressure control එකේදී flow එක ඉක්මනටම වැඩි වෙලා inspire time එක තියෙනකම්ම flow එක හිමීට අඩු වෙනවා. අඩු වෙන්නේ ඒ අපිට අවශ්‍ය inspiratory pressure එක maintain කරගන්න අවශ්‍ය ආකාරයට flow එක අඩු. So this may not be very easy to understand, but that's the difference. Right. So volume guarantee ventilation in preterm babies has been evaluated in the last two decades and is now standard of care. We also have to start doing this. So last 2 decades, volume guarantee product study newborns. So meta-analysis of trials reports that it improves short-term outcomes to discharge and some complications of premature. So I will come to that in a minute. So volume guarantee ventilation has been shown in clinical trials to be as safe as pressure-limited ventilation with potential benefits, including reduction in duration of ventilation, intraventricular hemorrhage, and the ARDS. මේ ටික පැහැදිලිවම literature වල ඔප්පුවෙච්ච කාරණයක් තමයි duration of ventilation, intraventricular hemorrhage, and ARDS. සමහර literature තියෙනවා chronic lung disease වල වෙනසක් නැහැ. But there are new literature which are emerging that the incidence of chronic lung disease is less with volume guarantee ventilation. The Cochrane review, pressure control versus volume guarantee, no effect on mortality. So mortality can actual effect. And this is the old literature, no effect on incidence of bronchopulmonary dysplasia. But now there are new evidence emerging that effects of bronchopulmonary dysplasia is in terms of bronchopulmonary dysplasia, it's better. The volume guarantee ventilation is better, but this is some old literature. And the neurodevelopmental outcome, there's no difference. A significant reduction in duration of intermittent positive pressure ventilation. So when you go for volume guarantee ventilation, the duration of ventilation is less, and reduction in severe intraventricular hemorrhage, and also and reduction in the rate of pneumothorax. Air leak syndromes. Air leak syndromes are much less when you use volume guarantee ventilation. So there are enough and more advantages to practice volume guarantee ventilation. And this is another slide from a peripheral project from UK. And less grade 3 to 4 hemorrhage, interventricular hemorrhage, it reduces by half, and less hypocarbia and decrease in air leak syndromes. So a lot of advantages. Right. And this is another Cochrane database review from 2017. And this review concludes infant ventilated using volume target ventilation modes had reduced rate of deaths of bronchopulmonary dysplasia and pneumothorax and hypocarbia and severe intracranial pathology. So this says even the mortality and the bronchopulmonary dysplasia is also less in volume guarantee ventilation. So initial settings. One of the most මොන modes වලද අපිට volume guarantee ventilation කරන්න පුළුවන්. Volume guarantee ventilation කරන්න පුළුවන් CME mode එකෙත් පුළුවන්, AC mode එකෙත් පුළුවන්, SIME mode එකෙත්. So these are any of these modes you can use volume guarantee ventilation. So how to select? If you look at, this is only example, but it will be different from ventilator to ventilator. I have just taken a picture of the Sophie ventilator. So when you select the SIME mode, when you want to select the SIME mode, and it will pop up two windows under SIME, standard and ITT or pressure support ventilation. You need to select ITT or pressure support ventilation. Then only it will give you the volume adjustment window. So you go for SIME and then ITT, then there's a window for you to select the volume, whatever the volumes that you want to set. So initial settings, if the baby is less than 1 kilogram, you can use the either AC mode, but add volume guarantee and tidal volume 5 ml per kg. And you can set the Pmax. Pmax. You ask the machine, okay, you do this all this job, but don't exceed your pressure more than 25 centimeter water. That means you are setting the PIP limit. But we have no control on the PIP. It will do change the PIP, whatever the PIP below 25 centimeter water. And PIP you can set about 5 centimeter water. Inspiration time standard 0.3 seconds. And backup rate. Always you have to put a backup rate about 40 per minute. And this is the initial settings for a baby with less than 1 kilo. And if the baby is more than 1 kilo, then again you can set the tidal volume 4 ml per kg, and Pmax you can set it as 30 centimeter water. That's a PIP limit, and PIP can be 5 centimeter water. This can change depending on the baby's situation and the parenchymal disease. You can change these things, but these are standard. And inspiration time 0.335. And backup rate you can set as 40. Right. So adjust the tidal volume. Now you start with volume guarantee ventilation and see how the patient is doing. And say for example, if you set your tidal volume for one kilo baby 5 ml per kg, it doesn't mean that 5 ml per kg tidal volume is going to settle your baby with 5 ml per kg. Baby might need more. Right. So you have to do that. You have to assess that by looking at your gases and saturation and the blood gas. And if the volume blood gases are not good, and if the carbon dioxide washout is not sufficient, and if you have more respiratory acidosis, you may have to increase your tidal volume. You can't stay on 5 ml per kg. You may have to go up to 6 ml per kg, or maybe sometimes 7 ml per kg. But your increment should be 0.5 ml per kg. And also, you can increase the backup rate. Backup rate is the ventilator rate in simple. So you can increase the backup rate by 5 to 10 and do the blood gas. Every time when you do a change, do a blood gas within 30 minutes to 1 hour and see whether your changes have improved, done any improvement. So Pmax limit must be adjusted periodically. Now, if your Pmax is, say, I told at the beginning, for example, 26. If it is 26, but you can see the ventilator is delivering the target tidal volume with a PIP of 16. So if the ventilator is delivering the target tidal volume with a PIP of 16, if your Pmax is 26, that is not something good. You need to bring down your Pmax somewhere close to the working delivered PIP by the machine. So for example, you can set it around 20. So that is a safe limit. And if the delivered PIP is more than 26 centimeter water, if the machine 26 centimeter water, a PIP to deliver your set tidal volume, then you need to consider to change your mode to high frequency ventilation, because otherwise you will be using very high pressures. This is not something new. අපි හැමෝම දන්නවා සාමාන්‍යයෙන් PIP එක මේ වගේ රේන්ජ් එකට එනවා නම් 24 26 වගේ PIP එකකට අපි යන්න හදනවා නම් අපි හැම වෙලාවෙම අපි ඒක try කරනවා high frequency ventilation වලට change කරන්න. So same thing, if you require higher pressure to deliver your target tidal volume, you can always change to high frequency ventilation. So adjustments when carbon dioxide is high, carbon dioxide වැඩි නම් බලන්න පුළුවන් දේවල් ටිකක් තියෙනවා. Is the set tidal volume and the backup rate is adequate. So tidal volume එක බලන්න. So example, whether it is 5 ms per kg or 6 ms per kg, the tidal volume එක deliver වෙනවද කියලා බලන්න. And backup rate. If the backup rate is, say for example, if the baby is not breathing and on, especially on SIME, if your backup rate is 20, if your carbon dioxide is high, it's obvious that you need to increase your backup rate, maybe to 30, 35 or 40, if the carbon dioxide is high. Is the tidal volume lower, alarm is going off. So tidal volume එක අඩුයි කියලා alarm එක වදිනවා නම් තොර අපිට බලන්න අපිට පේනවා tidal volume, delivered tidal volume is less. So then you may have to increase the tidal volume. That may be because your pressure limit may be high. So tidal volume low වෙන alarm එක වදින්නේ අපේ pressure limit එක අපි adjust කරේ නැත්නම් machine එකකට බැරි නම් tidal volume එක අපි set කරපු tidal volume එක deliver කරන්න අපි කියපු pressure එක ඇතුලේ machine එක alarm. Then we may have to adjust our pressure limit for the machine to deliver the tidal volume. Exclude airway obstruction, ET obstruction, ET dislodge, ඔක්කොම අපි normally බලනවා. එතකොට මොනවා හරි pneumothorax තියනවාද, all the other things, mechanical things, technical things, all that you have to check. Is the Pmax limit set adequate? So that also I have said. And enough inspirate time to reach the peak. අපි inspirate time එක adequate inspirate time එක පාවිච්චි කරලා නැත්නම් machine එකට අපි අවශ්‍ය peak එකට reach කරන්න time අඩු වෙන්න පුළුවන්. ඒකට 0.3, 0.35, 0.36 වගේ inspirate time එකක් තියනවාද කියලා අපි බලන්න. And does the baby need a chest X-ray? So carbon dioxide retention එකක් තියෙනවා නම් මේ ඔක්කොම හරියට නැත්නම් you have to decide, check the air entry and see whether you have to do a chest X-ray to exclude any air leak syndromes. And adjustment when the carbon dioxide is low, when there's too much of carbon dioxide wash out, rate. See whether you can come down in the rate and see whether the baby is agitated and whether the baby is sedated. And auto triggering. If there's water inside the ventilator circuit, there can be auto triggering. And auto triggering can cause unnecessary carbon dioxide washout. And the sensitivity and the circuit free of water. Sensitivity, you know what is sensitivity in the ventilator. If the sensitivity is too much, if the ventilator is so sensitive, even sometimes heartbeat can trigger as a trigger for breathing. So sometimes if you are on AC mode, there can be unnecessary triggering, which can cause a lot of carbon dioxide washout. And finally, the tidal volume. If there's a lot of washout, and try to reduce the tidal volume, and your tidal volume may be too much. And if you can manage the baby with small tidal volume, that will be safer, and that will cause less volume. So weaning, allow weaning, deliver PIP to be self-wean. That's what I said. So with time, with achievement of the normal tidal volume, the PIP will be weaned automatically. So let it wean automatically, and you will know how much PIP you are using. And avoid over sedation during weaning, and try to minimize sedation during weaning, because baby has to breathe. And if the baby does not breathe, then the weaning will not be successful. And once the set tidal volume is at low end of the normal range, which is 4 ms per kg, so if the tidal volume is 4 ms per kg, and then let the carbon dioxide to rise a bit. So let it come close to 50, and then the baby will start more and more breathing, and the baby will have a better breathing effort, breathing drive. So up to 450 carbon dioxide is not harmful. So if the tidal volume is too high, resulting in high pH and more than 7.4, the baby will not have a good respiratory drive. So there will be a lot of washout, and the carbon dioxide, the pH will be also high, and the baby's respiratory drive will be less. So always make sure that baby has a good, reasonable carbon dioxide level in blood gas to have a good respiratory effort. And over distension with normal carbon dioxide may be addressed by reducing PEEP. And if your X-ray is showing over distension, but with normal carbon dioxide, and look at your PEEP, you may be able to drop down your PEEP. Right. So extubation, and consider extubation if the mean airway pressure is consistently less than 12 centimeter water in 1 kilogram. So this normally we do it even in pressure control ventilation. Even pressure control ventilation, if your PIP is around 12 or less than 12, you try to extubate. But your auto weaning, during your auto weaning, if the required tidal volume is delivered with a pressure of 12 or less than 12 centimeter water for a 1 kilo baby, that baby is ready for extubation, and make sure that the baby is also not receiving a lot of oxygen, maybe less than 40% of oxygen. And if the delivered PIP is less than 15 for a baby more than 1 kilo, again that baby is ready for extubation. So with set tidal volume 4 to 4.5 milliliters per kg and FiO2 less than 35%, blood gases are satisfactory with good sustained respiratory effort, then baby is ready for extubation on volume current ventilation. So that's basically, I think we will discuss any questions after that. Uh, Basically, in nutshell, very basic understanding about volume current ventilation. So in summary, we discussed why we are bothered about volume current ventilation and what is the difference, why we should know about volume current ventilation, and what are the advantages and what are the evidence of using positive evidence for using volume current ventilation. And we discussed few things about pressure limiter versus volume current ventilation and evidence and initial settings and adjustment and weaning and extubation. So my take home message is you need to start studying on volume current ventilation. And there's one more important thing I want to tell you. There's what is something called reverse engineering. If you are not familiar, අපි කවුරුත් එච්චර familiar නැහැ volume current ventilation එක staff එක familiar. Nurses are familiar with that. But still you can do just something called reverse engineering. That is called you can change to volume current ventilation at the beginning and see how much of pressure is required to deliver your target tidal volume. Say for example, you have a 1 kilo baby and you have given surfactant and you ventilate and change to volume current ventilation. I'm not asking you to continue volume current ventilation until you are familiar with that. Change to volume current ventilation and set your tidal volume and just look at how much of tip or the pressure is required to deliver that much of tidal volume. And you know how much of pressure is required and see whether baby is comfortable and your oxygenation is good with that tidal volume. And then you can switch back to your volume pressure control ventilation, but you have some understanding of the pressure that you have to use. Say 5 ml per kg tidal volume is can be achieved with 14 centimeter water for a PIP, and you can go back on your volume pressure control ventilation and set your pressure 14 centimeter water rather than setting it to 18 centimeter water or 20 centimeter water, which may be higher than required pressure and also will cause barotrauma as well as volume trauma. Right. So that is basically end of the presentation. I'm happy to take any questions.
Sir, we have one question from Dr. Samantha.
Yes.
Whether we have to use cuff tube for volume guarantee ventilation.
I think that's a good question. Yeah, okay. Volume, now, first of all, this tidal volume. Now, there are two tidal volumes when we talk about volumes. That is inspiratory tidal volume and the expiratory tidal volume. So what we are concentrating, what we are interested in about expiratory tidal volume, because now what inspiratory tidal volume may not be as same as the expiratory tidal volume, because there are some loss of volume during inspiration. So there's loss of volume through the circuit and also through the endotracheal tube and the vocal cords. So there is always some leakage, and there's always some leakage through the vocal cords between the vocal cords and the endotracheal tube, and therefore what accurately goes in is not the what measures as accurately goes in may not be what is coming out. So what actually goes into the uh, alveoli is measured as the expiratory time volume. So expiratory time volume is the one that we normally look at. So to prevent that, the answer is cuffed endotracheal tube, but we don't use cuffed endotracheal tubes for newborn babies because that can damage the trachea. So we don't have to use cuffed endotracheal tubes, but that is only for pediatric and adults. This volume carriage ventilation can be easily done without cuffed endotracheal tubes. I know there are cuffed endotracheal tubes for uh, size 2.5, 3.5, but to my knowledge, we are not practically using because of the risk of the trachea damage. Any other questions?
We have another question from Dr. Nibras. He's asking whether we can use the Newport ventilator, which has the flow sensor, which is connected distally. I think you already answered. If you want to add anything about that.
Yeah, I think the flow sensor, there's no flow sensor for Newport ventilator. The flow sensor, it is the measurements are taken distally, which means within the machine. It does not have a flow sensor connected to the intertracheal tube. The ordinary Newport ventilators, the famous Newport ventilator that we are using. But Sophie ventilator and Eve ventilator and the other one, the Accutronic ventilator. All those ventilators have flow sensors. But you can look at your ventilator and it's very easy to spot the flow sensor, which is connected to the endotracheal tube and the between the endotracheal tube and the circuit. Another question.
I would like to ask one question. Until we develop a local guideline to start this volume guarantee ventilation, because it's a new thing, can you give us a reference or another guideline to use to practice, which is at acceptable level for our standards and practices?
Yeah, we don't have a local guideline, but there are some international guidelines. I mean, at NHS guidelines are there. I think Priyanka has joined, right? Priyanka can say something about it. There are Australian guidelines and UK guidelines and also USA guidelines. We can, I mean, there's not much of change. We can start using. I will share. I will get one reasonable guideline and share with in the group.
Yes, Saman, thank you. I think it's very, very nice, the lecture. First, appreciate your dedications to prepare slides and doing these lectures. This is very good things for people to understand the things very simply. Well, I can give the input regarding you explains nicely everything was a volume guarantee. There's no doubt in the world, the volume guarantee it's superior than the pressure control ventilations. But the limitations, the practical things, my observation from Sri Lankan and here, it's the flow sensor. In the Sri Lanka, we have the big issues with the machines and the sensors maintenance. If the sensors are not working properly, our aim will not get into actions. That's a problem. Because these flow sensors are very expensive as well. We are, I mean, not maintaining the regularly all those things and the validated and calibrated, so then the wrong volume will deliver and then they end up with a disaster. That is the main things that my observations. That here what we do is it's no pressure control ventilations at all. There's a volume guarantee ventilations we do. For that, the machines we need to calibrate and the technical supports we need to get into optimize. That's the one things I need to just highlight with the team. The other thing is regarding this guideline. It's very easy. I can share one of the guidelines what we use here. It's nothing, I mean, difficult. It's very simply, we will start as you explained, 4 to 6 ml per kg in between VT, and then set whatever the SMA with the PCAC mode depend on the circumstances, how the baby is active and the breathing. Another thing is, are we still in Sri Lanka using sedations regularly for the neonatal ventilation? No, I don't think so. We need to, because maybe 5 or 6 years before we use a lot of sedations. I think there's no need to use the sedations. The good thing is that the stay in the ventilator, the number of days is less because we are not using any sedations here. And the auto weaning of the PIP, we know that's when the mean pressures come down, okay, we can give the high flow or CPAP, depending on the situations. It's very easy to decide when to extubate. That's one thing is advantage I want to highlight in the volume guarantee ventilations. The other thing is I can add on, if anybody wanted further clarifications or any doubt, at any point they can contact me either WhatsApp or a Viber, so I'll be able to help out further.
Right. I think Vasanta has raised hand. Vasanta? Jitma, I think some are raising hands. You can see Vasanta has raised.
Yes, sir, she can talk. I just allow her to talk.
She's muted.
Meanwhile, she's coming to pictures. Someone, the other thing is this cuff tube or non-cuff tube. It's dependent on the ventilation. It's made for the accepted certain or a compensation certain degree of leak. So it's dependent on the machines. I'm not sure which machine is how much. We use in the Draeger 5000 machines. It's so intelligent that one will compensate up to 60% of leak. So we can use the small tube, and the machine is intelligent. Machine will decide, okay, this much is a leak, so we'll compensate. I think SLE machines maybe 30% or 40% like that, if I'm not wrong. Yeah. So it's dependent on the machines you can see. The other thing is the machine will show that's how much leaking as well. So in that case, you know that, okay,
That is the main problem with the Newport ventilator, because the volumes are not accurate and the leak compensation is also not very accurate. But we are managing. Pressure control ventilation we are managing.
Yeah.
Any
So
other
we have
questions?
another. So we have another question from Kanchana Sanjeevani. Whether we can use volume guarantee ventilation for non-invasive ventilatory moves?
No. Volume guarantee is mainly for intubated patients, but because again with the interface, you can't take the expiratory tidal volume. So in non-invasive modes, it's very difficult to do the volume guarantee ventilation.
I don't think there's any indication for a volume guarantee in the non-invasive. But for the HFOV, we can use a volume guarantee. So that's another thing is whether the machine support or not. What we practice here, even HFOV, we use the volume guarantee. But it's very less tidal volume. We'll need to explain a little later for that.
Anything else?
I think so. I think that's all for the questions, sir. I don't know whether Dr. Samantha, Dr. Vasanta wanted to speak anything.
And finally, I would say if anyone wants endotracheal tubes and central venous lines, I have some stocks, donations, and also nitric oxide I'm sharing. But please contact me. I can give you endotracheal tubes, nitric oxide, and some Pimicat. I have got some stocks of Pimicat. And also I'm getting a donation of nitric oxide, about 50 cylinders from a Singapore donor. And again, Primicat and blood gas machine cartridges. So that's, we are on the discussion, and hopefully within 2 weeks we can finish that. And the first consignment will be nitric. Okay, so shall we